So the challenges that face me as a sports physiotherapist, obviously the appropriate management of musculoskeletal condition, the assessment and advice regarding the benefits and risks with children with chronic illness and chronic injury. And every day I'm asked in the clinic by parents and coaches how much sport is too much really. I mean, it's an ambiguous question, and how you answer that, we'll try and do that throughout the presentation. So every day I'm encouraging appropriate behaviour of parents and you guys as coaches. So one slide to consider before we get through the guts of the presentation is to consider the difference between adults and adolescents. So the articular cartilage is thicker in a young adolescent, and it has the ability to remodel. Tendon attachment sites are weaker, are called apophyses, which they can cause avulsion injuries. So in other words, when kids are growing, they have growth plates in their joints, and the growth plates are quite weak with the tendon attachments, and they can be pulled away from the bone. And I'll go through that in depth when we see it. And I know I'm not asking you to become physiotherapists by the end of this presentation, nor I'm asking you to be sports medics, but I suppose you guys as coaches will come across certain injuries, and it's important that when you hear the terminology mentioned that you recognise what the injury is, potential time lost as players, and return to play protocols. And it's really important that you know a small snippets of terminology and what the consequences could be for an adolescent. Because these type of injuries that I'm going to discuss throughout the presentation can be career threatening if they're not addressed as adolescents. And it's just so important to just have a little bit of terminology even here today, and that would be enough. So common injuries I clinically encounter every day, as you can imagine, adolescents will receive the same type of injuries as adults. So they will get shoulder injuries, spinal injuries, pelvic, hip, knee, lots of overuse injuries that Jared spoke about. Concussion, Jared went in depth. I have a few slides on it, but we'll quickly go through that as well. Obviously fractures, and the hypermobility syndrome is one I encounter a lot. Basically what it is, it's just some kids in their teenage years get like hypermobile joints. Their ligaments become very flexible in their shoulders, knees and hips, and the capsule around their joints become very flexible. I've had a couple of patients in the last year that would suffer so badly from it that even just moving their shoulder kind of subluxes and comes in and out of their joint. So you can imagine how detrimental that is to a young hurler who enjoys just poking around, and if his shoulder is dislocating when he's just dressing himself in the morning, how that can affect him. So every time they go through growth phases, this type of hypermobility syndrome becomes very, very tricky for me to treat, but also very tricky for the parent and detrimental for the young kid's confidence. So hypermobility syndrome, if you do hear about that among your players, it's quite serious. And obviously to use a chartered physio and a sports medic is vital throughout all the injuries I discussed. Sorry guys. So other stuff, the real life situations. Overtraining syndrome I'm going to talk about, and basically player burnout is what it's called nowadays. And the vicarious parent or coach. So we all come across, I mean I'm from a non-GA family, so I didn't encounter it as a young kid, thanks be to God. But there are parents out there that are kind of living their lives through their kids. And mothers and fathers, they're present at every training session, they're present at every match. They're present in my rehab gym with the kid, they're present in the clinical room, which is very, very relevant and necessary. But sometimes they push their kids too much. And some coaches push their kids too much. So that leads to overtraining syndrome, and I'll talk a little bit of that towards the end. So shoulder injuries. I mean, in the last year or two, I've seen an awful lot of teenage shoulder dislocations. I would say 85% of these will re-dislocate. So therefore we have the rehab versus surgery debate. I mean, you can see from the middle slide here is what the most common one that happens is called anterior dislocation. This is the normal anatomy of the shoulder. So my approach to this nowadays is that we get a thing called what we call an MR arthrogram, which is a dye-injected MRI scan. And we usually go to Santry to one of the top surgeons up there, a lady called Ruth Delaney. She's just home from the States, and she's worked a lot with the NFL, with the Patriots, and she's quite a good surgeon. And our approach to this now is to get that scan done, and if there's damage done within the joint, if there's this little thing called a labrum that is torn badly, and the ligaments within the shoulder joint are damaged, well invariably I'll always push the parents to get this stabilised by surgery. I know you might think it's quite drastic from a 14, 15, 16, 17, 18-year-old having stabilisation surgery, but believe you me, they will re-dislocate. No matter how much rehab they do, they will re-dislocate at that age. So I push parents nowadays to have the surgery. It saves time, it saves money, it saves all the trauma associated to the kid. Can you imagine if he keeps re-dislocating before he's the age of 20, he's not really too keen on pursuing any more of his career. I've had a kid lately with the tip minors that had a traumatic dislocation. He battled with rehab for, I'd say, 6 months, did really, really well. He re-dislocated. We went to Sanctuary, had the surgery. Everything went swimmingly well. His rehab was fantastic again. He came back in the next 3 weeks after he's returned to play after 4 months of rehab, had his arm out to stop a player on his opposite side and dislocated the opposite shoulder. So he was humming and hawing about whether he should go for the surgery, and his parents were quite concerned. We pushed him for the surgery. He's had both shoulders stabilised and he's doing really well at the moment. But that's just an example of what can happen. And he had that hypermobility syndrome. So having the shoulder stabilised straight away is probably the best thing to do for these under 19-year-olds. Jared touched on this with the hip injuries. You see the top one there, femoral acetabular impingement. Really topical nowadays. And we do hear a lot of GA guys going for what we call hip impingements and resurfacing, and this little thing here called a pincer and a cam. So what this is basically, you have your hip joint here, and you have your ball and socket. So you have your socket area here and your ball here. What happens with repetitive trauma, which is the multi-directional aspects of hurling, and you can imagine when they're sidestepping and striking the ball, you do get what we call impinging of the hip. What happens then is an extra little bit of bone is laid down, and it causes a little hood-like formation. That hood-like formation starts to fray on the cartilage, and the cartilage starts to get damaged. The other one is a cam. Basically, the bone is laid down here on the neck of the femur that also impinges on the cartilage, and the cartilage becomes damaged. And you end up having a thing called a labral tearing. It shortens the kid's career if it's not clinically diagnosed. The constant debate here is whether it should be repaired or scoped or not. There's some really top-level hip surgeons in Ireland now, and they are scoping these and resurfacing them, and the kids do make some great recoveries. But we as physiotherapists do clinical tests for this syndrome. My advice is that there's just 4 or 5 tests have to be positive out of 6. Then you look for the x-ray. If the x-ray is positive, then you might pursue an MRI and a surgical review. But the tests have to be done by a chartered physio. And I would urge all of you guys that are using medical professionals out there to use chartered sports physiotherapy with masters, if possible. Because we're trained at higher levels to diagnose these types of injuries. I've had lots of kids come into my clinic and they've just gone straight to these surgeons without anybody assessing them, x-ray and MRI. And if you walk into a surgeon's office, he's a surgeon. He's not going to have a cup of coffee with you. He's going to obviously book you in for surgery or for a scope. And a scope might be just to have a look. So I would urge to get the clinical test done, because hip impingement does exist and it's a very real thing. It shortens people's careers, but unfortunately, if it's not diagnosed properly and rehabbed, you might never have to go for a scope. So it's just one thing that we will come across. So I urge you to use the right medical professionals. Pelvic injuries, again, pubic bone overload. I suffered a big time with this when I was 17, 18, up to 20 years of age. Again, it's just basically doing too much and not being mechanically assessed and not having recovery. I won't go into it too much because it's very medically this slide, but you can see you've limited range of movement in your hip. You probably have some really tight hip flexors down here, and you see all the kids coming in nowadays that they have the big curvature in their lower back, really tight hip flexors, weak core muscles and really tight groin muscles, and that a lot of multi-directional sidestepping movements overloads the pubic bone, and that can be chronic inflammation. So knee injuries, and Jared alluded to a couple of these. Obviously we all know the dreaded ACL rupture. Last year's minor team we had one posterior cruciate rupture. That is not really surgically repaired. It's usually just braced and rehabbed, and they do make a full recovery. The knee can be left with some instability in it, but they can function well without a posterior cruciate ligament. ACL rupture has to be surgically repaired to play at the top level. Has to be. Medial ligament tears, you hear a lot about this as well. If they're got within the first few days, they're braced for 6 weeks in 30 degrees. So in other words, the brace on their leg, you've probably seen guys walking around with these, and you're limited to 30 degrees movement. That's to allow the medial ligament, which is the inside of the knee, to heal. Again, it goes back to, and I repeat myself a lot over the presentation, about using the right people. So if you use the right people, this ligament is diagnosed very quickly. It's put in the brace and they have a brilliant chance of making a full recovery. If it's not diagnosed and you're not referring people on to the right people, well then obviously it's missed, they go back playing with an unstable knee and then they do more damage, and they've accelerated arthritis through the inside of their knee. Meniscal tears, or what we call your cartilage tears. A tricky one in adolescence, the kids that you're dealing with. Remember I said at the very start that cartilage has the ability to remodel. So we don't like sending these kids for scopes because the cartilage can actually heal, and as it wouldn't in an adult. So what we tend to do, if you have a meniscal tear within a knee, if it's obstructing the knee joint and it needs a scope and they can't bend and straighten their knee, obviously that needs a clinical investigation and surgical review. But if it's just a little bit of a tear within the cartilage, the best rest the patient and it will make a full recovery. I see a lot of what we call kneecap dislocations and subluxations, but these are dealt with rehab only. So ACL ruptures, there's an increased prevalence in this in the last 10 years. That's due to increased participation rates. There's a lot more imaging modalities. In other words, there's a lot more MRI scanners. So you've obviously 2 in Limerick, we've a couple in Cork, Waterford, Kilkenny, Naas, Dublin, Galway. We're surrounded by them now. So that's why these injuries are found more nowadays. Before they weren't being picked up. And MRIs are cheaper now. Health insurance is out there, the GA insurance is very good. So we're finding out a lot more about these injuries because we're availability of scanners. And also, we have a lot more skilled clinicians in our areas now to refer people on to. ACLs are more common with the young female adolescents. For one reason mainly is that they have a wider pelvis. So they'll have what we call more of an angular through their femurs, and their femurs come in here, so there's more of a torsal twist on their femur straight away. So that's why it's more common I see in young females. I've seen the youngest, I think, young female I've had in the clinic over the years was a camogie player, and she's an international soccer player as well, and she did her ACL at 14. She's at 19 now and she's made a full recovery and is playing at the top level, but you will have them as young as that. So, I mean, sometimes you guys, when you don't have someone present at a match, you're going to be the first stop. So you're going to be the first person to talk to the kids. If a kid says to you that he's gone down in a match and you meet him after and you have no medical professional there, if they describe to you that they felt a pop on their knee as they fell, that's really serious. That means something has torn. Invariably it is the ACL. If you see swelling within 3 to 12 hours, massive what we call joint effusion, that the knee blows up, that's a big sign that the ACL has been ruptured as well. Then obviously if they describe that the knee gives way, that's a sign of instability. Again, another really big clinical sign. Then again, like I said to you before, if all of these things are present, obviously straight onto your chartered physiotherapist. We do specific tests that we can diagnose it right on the spot, but we always send on for an MRI just in case to make sure. So again, that's just in case you have nobody there. It's very important to just listen out for these small little terminologies of the kids saying he felt a pop. You need to make sure that you talk to the parents and they get to see the right people. So what is an overuse injury? I know Ger touched on this. So as you can imagine, a lot of us, you're all former players I presume as well, and like overuse injuries are sustained from repeated action, and repetitive strain injury, like the pelvic injuries we discussed, as opposed to acute injuries which occur in an instant, which is a sprained ankle, an ACL rupture, or a traumatic dislocation. The stages of the overuse injury, you might get some of the kids saying to you guys that, you know, I'm feeling a bit of discomfort when I'm warming up, and then it develops into, yeah, the discomfort goes in the warm, but I'm sore at the end of the game again, or the end of the training session, that soreness is back. And then they might develop into this discomfort is there, and it's just getting worse all the time, and eventually they're in pain and discomfort all the time. They're in pain sitting at home watching TV, they're in pain first thing in the morning, or they're in pain just literally sitting down at school. Overuse injuries then, I suppose, you could talk, I mean, a lot of this stuff, lads, I'm touching on, you could talk all day about every one of them. So I'm trying to make it fairly broad, so forgive me if there's a lot of stuff to take in, but the overuse injuries then, like the medical terminology for some of the tendon growth plate injuries, we call it apophysitis. I'll touch on them individually, and I'll touch on two really important ones, in the knee and in the heel, and sometimes around the pelvis. They do exist around the growth plates, as I discussed. As I said earlier, the bone grows faster than soft tissue. It can be very, very painful for the child. Communication and rest is essential. So communication from me to the parent and from me to the coach is so important to describe what the kid is going through and how we deload the kid, and we don't overload them and cause them this to develop into something really serious. Right, so this one, I don't know, some of you guys in the audience might have actually suffered from this yourselves. I see this a lot coming into the clinic. These medical things are called after people that discover it. So it's called Osgood Slatters. Basically what it is, it's where the patella tendon inserts into the front of your tibia, and there's a little growth plate there in the front of your tibia. So if the kid has got tight quads and is always training or kicking and running, this patella tendon starts to pull on the piece of bone. They get really sore and inflamed here, and sometimes can pull the bone away. Osgood ladder is very, very, very painful. It only happens when you're going through growth spurts. Rest rehab, mechanical assessment, condition education to the parent and the kid and the coach, rest periods. Every time they go through a growth spurt, expect to get sore, resting them after the growth spurt, and it usually disappears. But if you do hear that over the years, a thing called Osgood Schlatter's, it's a painful syndrome, and it is very real. One I see a lot in the clinic too is this other one called Sever's disease. It's to do with the Achilles tendon down at your heel. Again, you can see this little growth plate here at the bottom in kids. They don't fuse up till in their late teens. So if they've really tight calves, the Achilles tendon is pulling on the heel bone. If they're playing a lot, literally out training twice a day, kicking around with their friends, just always running, they can pull this tendon away and cause really badly inflamed heel bone. I've had kids so bad with this that the parents are on board, they rest the kid, they take the gear bag off him at the door. He's at home, he's out farming, he's wearing wellies, he's got flat feet, he says he's resting, but he's not really resting, he's out pucking against the wall. They've been so bad with this that I've had to stick him in a fracture boot up to their knee and put him on crutches, that they just physically won't rest with it. And it won't go away until you rest. It sounds cruel to do that to a kid, but sometimes you have to because it just will not go. So again, if you hear about these type of apophysitis, tendon injuries in kids, they are very real and can be very debilitating, and it might be taking the kid out for 6 to 8 weeks. So the overuse injury in general, if you think about it logically, again, the kids will go through growth phases. That leads to poor flexibility. Inadequate recovery causes the pain, and if you don't get the really valuable assessment here, well, obviously they go through the next growth phase, and then obviously you're looking for a recipe for disaster if you don't intervene. So how to prevent these overuse injuries? Unfortunately, sometimes you can't. Some kids are genetically predispositioned just to have these growth plate issues, and there's nothing we can do. But it's to recognise them and treat them and prevent them getting worse is the key. So obviously the warm-up is good, the proper equipment. Runners and shoes are really important. I know it sounds fairly corny to say that, but if you have kids playing on Astro, making sure they're playing in the right runners, that they're not wearing football boots on the Astro all the time. Even if they're just going to school, that they're in proper shoes and proper runners, stuff like that. So if you see kids that you're training and they're in shabby footwear, obviously it's a good time to contact the parents. Again, increasing the training no faster than 10% per week, and really appropriate screening at the end here is vital. So again, consult your chartered physiotherapist. So if there's pain, obviously there's inadequate rest, it develops into a chronic situation, that gives the poor performance, it gets back into what we acute pain, and back we go again. So again, the physio needs to intervene here somewhere, preferably as soon as the pain comes here, before this all gets out of control. So the differences between the growing adults and the adolescents, we spoke about this already, so there's just a few little bits there if you want to read through it. The growth phases are essential. I know I keep repeating that, but they are really important to recognise that the kids do go through these growth phases, and you're going to see it every day. So the lack of appropriate muscle and strength and endurance, the poor core stability, the training errors, the faulty technique, the inadequate recovery, as we said, all of these are so important when preventing overuse injuries. So the GA 15 warm-up and stuff like that Ger spoke about, and we'll touch on that later as well. I know Ger has done this, so I'm not going to go through it as much as I had planned, but I suppose it is such a topical thing at the moment within the NFL, within rugby, and now within GAA. I think Will Smith has a movie coming out this weekend about it as well, so it's one of these things that we're going to hear a lot about. Just for anybody, just hands up anybody in the audience that has been concussed in their careers or has been concussed outside of hurling or GAA. So there's a decent percentage there. I had a concussion once when I was playing with Tip Seniors, and it was a good old pitch opener against Laois, and got a hospital pass and just got KO'd. And it's very real, it's a weird experience that you literally cannot remember what's after happening. I was on all fours on the pitch just getting sick and couldn't remember the game at all. I had to read the paper the following week to find out how much I'd scored. Went to A&E in Limerick, had the CT scans, everything was okay, thank God. But I played 10 days later against Waterford in the first round of the championship in Páirc Uí Chaoimh. And I was like a zombie all that week at work, and it's one thing I look back on now when I see kids coming into me. And I was only, 19, 20 at the time. I was a little bit older than the guys you're going to be dealing with. But it's very real, and it's not to be laughed at. The old school approach was like, he'll be all right. it's very, very real and can be potentially dangerous. You all know about the rugby stories. I'm not going to go on about them again. I've seen kids in the national rehab in Dunleary and teenagers and 20-something-year-olds with hemiplegia, like stroke victims, because they had really bad concussions, similar to having a car accident. I mean, it sounds very dramatic to have all this said, but from my point of view as a sports physician and a sports physiotherapist, it's very real. So all these little questions that parents have and kids have that you might be able to answer for them is what you maybe pick up from this presentation. Is like, you know, do helmets stop concussion and all this malarkey? Of course they don't. I mean, helmets only stop us from getting fractured skulls and, you know, and cuts. But I mean, if you get a jostle and your brain shakes in your head, that's concussion. Dizziness, blurred vision, just anywhere. We've all had it on the pitch. We might get it several times in a game. But that's what Jared talks about, the second impact syndrome. We've all kind of got up after a heavy tackle and had a few and shook your head and seen a few stairs. That's concussion. I mean, like it or lump it, people are unaware that is concussion. So you have to be aware of these little things and don't be that coach that pushes the kid back on, or don't be that coach that goes, "Ah, you'd be grand." Don't be caught like that, because if you have no medical personnel with you on the day of the game, that kid receives another impact injury and they're out cold and they have a brain injury. Where does the book lie? Probably it stops with the coach, because there's no medical people there. So that's what I would say to you. So, I mean, Jared's touching what it is. I'm not going to bore you to tears with all of it, but Jared's touched on most of it, so I'll quickly go through that. This one actually is obviously the talk about being fatal, and I know we heard about the schoolboy rugby player in the north that did pass away. And there's been a couple of other incidents in Australia there lately as well. I know they're all rugby related, but it's only, I think, and I hate saying this in touch wood, but I think it's only a matter of time that we have a high profile concussion within GA. And it could be in hurling, it could be in football, I don't know, but hopefully we won't. But this thing called chronic traumatic encephalopathy is basically what they talk about in the NFL, and it's about these little proteins called tau. I mean, they only figure out about these proteins in the brain when you die, so they cut your skull open and they have a good look at your brain and they see all these little proteins, and they're in the NFL players that have suffered from Alzheimer's and dementia. So if you get a concussion, a bad concussion, who knows, I have a few in my head, I don't know, some people that have been concussed here that put up their hands probably have it as well. We don't know until we cut our heads open if we donate our body to science, so we've no way of saying how bad we're going to be affected, but the best way we can do is try and prevent these second impact syndromes and pull people out. So the signs and symptoms are really important to recognise. The confusion, we're running into a player and there's no medical personnel there. Simple questions. Who are we playing? What's the score? Who did we play last week? This is the questions we ask the players when we want to the field, and if they get any of them wrong, it's out. And they get them wrong. And like, it's so hard for me as a physio sometimes, because being an ex-player, I have to kind of put my physio hat on, and I'm going in as a kind of Tipperary man and an ex-Tipperary hurler, but yet I'm a physio, and I want the player to stay on here, but my physio head rules me straight away. And the player doesn't want to come off. Of course he doesn't want to come off. I mean, he's in the middle of a high-profile game and he has a concussion, and he's trying to bullshit you with some answers. And he might even get aggressive with you and push you away and say, I'm fine, and you know they're not. So it's really difficult for us as medical professionals too, to implement this. It's not as easy as all the guidelines say, oh, this is the way it is, if in doubt, take them out. It's right, of course it's right, but it is hard for us, so I can only imagine how hard it's going to be for you as coaches. Your star player goes down with a concussion, and you've a free that has to be taken in the dying minutes of the game, and here's your free taker a little bit dizzy. You know, it's a dilemma, isn't it? I mean, we had that episode last year with Shemi Canlan, and he got spear tackled into the ground against Galway. And we went in, we did our concussion protocols. I held his neck in case he had a neck fracture. We cleared everything, and he reported that he was fine. We asked the second free taker to take the penalty, and it didn't happen. But these are little examples that you could look back on your careers down the line and say, well, what we could have done there any different. We did everything perfectly right. He passed all our tests, and everything was done perfectly well. But you'll always have people saying that he shouldn't have took that free, but he passed all the tests, so he was eligible to take that free. He did suffer some headaches for a few months after, but these are real things that happen on the field of play you don't hear after the game is over. So the return to play protocols are what Jared spoke about. You have to recognise the symptoms, report it to specialists. You have to rehab with the medical guidance. You have to rehab with the medical guidance. It's so important. That's all I'll say about that slide. These are little examples of what Gerard was touching on. I mean, obviously there's no activity in the beginning. You go to light, running, hurling drills, full contact, and then it's a full return to play. Marry these up, you're looking at physical and cognitive rest. Okay, that means, cognitive rest means, an example I can use in that respect is that you get a young kid that's had a concussion, and they go home and you say, like, go home and rest. And he goes onto the PlayStation and he spends 12 hours smacking around with the PlayStation. You might watch a 3D movie. I mean, his brain is getting absolutely annihilated there. That's not rest. I've had a kid have a concussion that wasn't reported to the clinic. It was just unfortunate, some plugged in. He went to the cinema that night at a 3D movie and collapsed in the cinema because of the stimulation that the brain was getting bombarded with. So they're little examples that rest means rest, and I don't mean to close the doors, to turn off the lights and get them lying in a bit. I mean just rest from schoolwork, rest from watching movies, and rest from playing the PlayStation and stuff like that. You'd be surprised what can actually impair recovery when kids get concussion. So Ger spoke about how we prevent injury, and I do recommend looking at the injury, the GA15 injury prevention warm-up. It is really good because if you're not really structured in your warm-ups, just look at that, and there is some really useful exercises in it. Mobility training, stability and core exercises, Pilates, yoga, strength and conditioning, and the last one here, like small things like getting a chartered physio or a good strength and conditioning coach just to teach players about their bodies and what their bodies need as sports people. And it's so important at that tender age. They're like sponges. They want to learn. So if you teach them about about their bodies, and again that brings me on to another point in that respect. Like when you group players, you'll have some players that are quite flexible, and you'll have some players that are quite stiff, and you'll have some players that fall in between both. So it's not always given a generic stretching program. It's really useful sometimes to categorize players with different groups, that some kids need more core work, some kids need more flexibility, and some kids need a bit of both. And that's really important to start implementing that and liaising with your strength and conditioning coaches if you're at that level, or liaising with your physiotherapist in that respect. So it's not always a generic program that suits everybody. So the screening is important. I look a lot at family history. So if I have a family coming in, or first cousins, second cousins, and I see a pattern of shoulder dislocation or ACL rupture, I mean obviously I'm going to worry about that, and I'm going to actually implement some preventative measures for the kids in that family that they make sure that they don't have another ACL rupture. So family history is really important. The rehab part of things is really important as well, and a structured, supervised gym program. I think we touched on that when we talked about the protein supplements and stuff like that. And I think Owen talked about it there earlier when he said that he was going off to the gym when he was 16. And I know nowadays nearly every gym session is quite structured, but it's so important for the kids at that age to teach them about weight training, to teach them the correct techniques, to teach them why they do weights. Because you have to say, like, we do weights and we do strength and conditioning to prevent injury, and another level then it's probably to improve performance, but ultimately it's to prevent injury. I mean, if they're sitting at home watching Geordie Shore, they're going to just do weights to look good. It's bullshit. Do you know what I mean? And that's what I'm getting coming into the clinic. These kids that are coming in are just ripped, and they're like, oh, they've no idea why they're doing it, and coming in with these because they want to be like the rugby lads, or going to school with some rugby lads. Oh, my mate's on a Leinster scholarship. And I went to boarding school in Cistercian College, Roscrea, and I played a bit of rugby down there at Senior Cup and Junior Cup, and I was exposed to all that stuff in UCE with the Leinster Academy guys, and yeah, that's what they do. But some of the GA guys are fooled by that, and they want to be like that, and they're coming in with just the wrong type of gym program. I'm still seeing it at GA level. I'm still seeing it, and it annoys me because weight training is done for injury prevention really, and to increase performance. But it's gone to a new level, and we just have to educate kids when they're at that tender age to know why they're doing it. That it's not to become like Hulk Hogan or Arnie Schwarzenegger or all these boys on TV. That it's to just tell them why we're doing it. So it's examples that might be on the GA15 program, and some examples that I suppose that are just useful. I mean, I know we're not going to go into a full strength and conditioning session here, but small core exercises, injury preventions for ACLs, just doing some trunk rotation, because hurling is so multi-directional, but it's a lot of torque and twisting, and you have to straighten up your torso, and doing small things like this for kids. I'm talking about kids now, we're not talking about adults here. Adults is a different game altogether, but if you just get little exercises going to teach kids why you're doing them, they'll remember that for their whole career, okay? You know, small things that's on the injury prevention, the GA15 here are the Nordic hamstrings, just to strengthen hamstrings and prevent ACL ruptures. And you do them pre-exercise, you do them pre-training, you do a couple of quick reps. And again, obviously, kids nowadays just need to be told what core stability is. And core stability is the engine room, and core stability is so important, and it's a term branded about a lot within strength and conditioning and within physiotherapy. But it is so important, and if you were just to implement some Pilates exercises, some core stability exercises, like the FAI, all the kids over in England, the IRFU, the IRB in New Zealand, Australia, they're doing some amount of yoga and Pilates at a young age. It's brilliant. I don't think we do enough of it here in Ireland within the GA. And kids nowadays, again, access to their phones are really good. They want to learn. But if we just give them structures of what core stability is and why we do it, because they want to pick up dumbbells and get like the rugby lads, but we need to be focused on why we do core stability. And that leads me on to what we just spoke about the kind of confused kids that come in or why they're doing stuff. So the ideal athlete, we call it the ideal hurler, in a sense, is going to be the one that has a lot of functional movement. So you have your kind of a core stability and your mobility. So mobility is essentially flexibility, and stability is your core strength. And then you move on to what we call functional performance, which is basically your strength. And as I said before, to improve your performance, it's generally that bit of strength. And obviously on top you have your skill, your hurling skill. So that's the ideal athlete, to have a good base, bit of strength, and a good bit of skill. And then you have the overpowered athlete, the guys I speak about that come into the clinic with all these overuse injuries and wondering why they have them. They're just in the middle all the time, just pumping iron non-stop. They're not really doing any core, they're not really doing any mobility, they're just real stiff. And again, they're not even picking up a hurley really. And then you have the under-skilled guy that's doing a lot of functional stability, good bit of gym work, and he doesn't pick up the hurley at all. You know, so they're the kind of kids you can see come in, and you have to categorize them every time, spot them, identify them, and put them in the groups that they should be in. And that comes from the conditioning course. A lot of you guys, probably in the audience, are doing some S&C stuff yourselves or dabbling in it. And it's important to take that approach. A generic program is not always the one to go for. So the kind of model I would like to do in my clinic, and I have done for years, I suppose you always consider hurling at the centre of it all. Okay? And what you have then is your strength and conditioning is vital. And as I said before, your core stability and mobility, they're really important aspects in kids. So important. I remember this presentation, we're talking about kids here, it's not always about adults. So this is really important that we're trying to emphasise every time. And at the top of that then obviously is speed, because obviously in hurling speed is really essential. And that was the kind of model I tend to follow a lot. Okay, so you have definitions here again, it's very wordy, but you know, your mobility and stability and what they mean, and that's essentially the core stability model. So the bigger picture here then is, and I know Jared spoke a little bit about this, about player welfare and stuff like that. So if you're thinking about, like, you have your player well-being at the centre, you have what we spoke about, your stability and mobility, you have your S&C, you have hurling, you've got training, load and other sports, and you have your nutrition and hydration. Up here then is one that is often forgotten about in this age group. Don't forget that they're at school, and like they're doing junior cert, they're doing leaving cert. Some kids are actually just gone that little step ahead, and maybe they've got the third level at 18. But this is a huge area too that we need to watch, because with player burnout and overtraining syndrome, a lot of it, as Owen spoke about, was the emotional burnout, not even the physical burnout. And the emotional burnout could easily be coming from school, college, relationships, family backgrounds, marriage breakups. I don't know, I've seen it in my clinic. I've seen kids come into the clinic and you just notice something else going on, and you probe, and who knows, they might have a friend that committed suicide, they have a relationship breakup themselves, their family life isn't good at home. So don't never underestimate this part. It's a huge, huge factor in player welfare, and to have the intuition to spot that, have the intuition to contact the parents or their legal guardians, to have a chat maybe, or have them present. Sometimes having them present, they don't disclose this information. So it's a tricky area with the age group really. So that leads me on then to talk about the whole issue of overtraining syndrome, or burnout as it's called in generic terms. But overtraining syndrome actually exists, and it is a syndrome. And it can be diagnosed physiologically, psychologically, and there's lots of tests you can do. So we're going to talk about what it is, we're going to talk about the signs, and we're going to talk about how you guys as coaches need to be able to recognise it. And that's the most important thing. So overtraining syndrome frequently occurs in adolescents who are training for competition and train beyond the body's ability to recover. Adolescents often exercise longer and harder as they want to improve and achieve their dreams. So we were that age, the boyhood. I still have that boyhood kind of fantasy in my head as I think I'm 18 all the time. I think I could go out in the morning and stay playing hurling, and that never leaves us as hurlers. You should always have that in you, that it's a game that you grew up playing, that you loved, and you couldn't stop playing, and you get older, your body gives up and you have to give it up, but up here you want to keep playing it. So remember too, like, kids will not want to stop training. I have big issues with some of the senior guys trying to push them out the door to go train, and they're always whinging and moaning, I don't want to train. But kids, you have to hold them back. There's such a big difference. There's such a big difference working with kids and adults. It really is. It baffles me every day of the week. I'm just constantly ringing parents and telling them to rest him and her, and then the seniors come in and they're whinging and moaning about something, and there's not a whole pile wrong, you just want to push them out to training. So it's an age group you have to hold back on, so it's not similar to seniors. So there's another few slides on that. So like, the inadequate rest and recovery is the big thing, and conditioning that requires a balance between overload and recovery. And too much overload or too little recovery may result in both physical and psychological symptoms of overtraining syndrome. So the signs and symptoms of overtraining syndrome. So I'm not just asking you as coaches to spot this. As parents, you should be able to spot this as well. And it's important at home as parents to be able to recognise this and implement some strategy. So feeling washed out, tired, drained, and lack of energy. Mild leg soreness, general aches and pains, pain in muscles and joints, sudden drop in performance is the big one. Everybody has a drop in form, be it 12-year-olds to 21-year-olds. That happens, but sometimes if it's persistent and it's really, really just dramatic, you have to start questioning it. The insomnia part I've seen, and the headaches obviously. So how do you recognise overtraining syndrome? As sports physiotherapists and my GPs tend to just take heart rate recordings. You can ask, as a coach, you could actually just give them a training log to fill out and see how much training they're actually doing. I've done that with a couple of, we had the big, and Willie will agree with this, over the last few years, like Tipperary have been very successful at football and hurling in underage. So we've had a couple of, last year they went to both our Ireland finals. So sometimes you have to give a training log to the dual players to see exactly how much they're doing, and it's phenomenal the hours that are stacking up that they're doing. From that squad, I had one kid come into me last year, and he booked in with me. He's a great kid, a real high achiever, type A personality, like, you know, real high level student. He's in third level now, but it's like around, you know, 550 to 600 points in the leaving cert. There's about 2 or 3 of them kind of people. But he just came in for a chat, and he was just basically offloading of how he was feeling washed out and burnt out, and just, you know, more from the exam point of view, but then he found it hard to go to training. Then he was afraid to tell the manager that he was feeling tired, he wanted to lay him down. Then the club were pulled up and he wanted to make the club senior team. It's happening all the time. And even just the chat for 45 minutes with me, and I had a strategy for him saying, this is the night you should study, this is the nights I'm going to talk to the management, you don't have to go training. You could see the relief of him leaving. He was just instantly improved, just because somebody was taking onus of what he felt was just the weight of the world on his shoulders. So communication is massive between parents, coaches and your medical professionals. So potential teams that would have existed with them kids that I would have seen over the last few years, I mean, if you just add them up there, I mean, I think they could be equivalent to 10 teams. And then, like, you're not talking about your other sports. Like, I mean, last year there was one of the lads was one of Leinster Schools cup rugby with Certain College Australia, and he started playing Irish schoolboys, and he was playing both codes at minor level with Tipperary, and his club senior, 21, hurling and football as well. And he was on the Leinster Academy as well. I mean, really talented kid, but he suffered from numerous syndromes after that. But thank God he's in good shape now. But these things exist, and no one knows what's going to happen with this age group. So you have to be really protective of them, and you have to be constantly checking on their welfare and checking with their parents. If you see anything at all that resembles overtraining syndrome, I think you need to recognise it, because what's going to cause? It's going to cause dropout. They're going to have negative emotions towards hurling. So the vicarious parent or coach I spoke about, so I see this a lot in my clinic as well. And it's usually good. I mean, in fairness, I can't go there and disrespect all coaches and parents, but there is the odd couple that come in that are just so hard on their kids, are so hard on them to achieve, and want them to achieve so much. And they can put too much pressure on them. I've had one side of a kid who come in, will have an injury purely just to get away from sport, and it mightn't even be that real, it just might be to get away from the pressure that he's under. So that does exist. So interference can lead to low self-esteem. It may present with physical complaints due to pressure. You get the emotional volatility, and it can lead to anxiety and depression among the teenagers as well. A vulnerable group, we always remember that. So the coach's role in general now, I mean, I'm not the expert here, you guys are the expert, but I'm just saying what I hear back from kids and vulnerable teenagers of the small things like to be reasonable in your demands, group players for reasonable chance of success. And Owen spoke about this, and I think there was a question from the audience about this bit here, about the overplaying the talented players, and I can understand that too. So there's times that you want to just give everybody a run out when there's challenge games or games that are less important, and not always put the pressure on the talented guys. Easier said than done. Obviously these little principles are easy to hear, and I know you understand all these already yourselves, but the last two are, I suppose, the most important to me. Like, try and always follow advice from the likes of me, and always respect the return to play protocols as they are evidence-based, and we're not making them up. I mean, we did several years college and degrees and masters, and we constantly research and we constantly attend seminars, and you know, we have some really high qualified people in Ireland now. So these decisions that we make are not just you think of your physiotherapist sometimes as, oh, he's the enemy, don't go to him, he won't let you play. Like, I'm talking about adolescents here. I mean, I'm very protective of this group purely because of what I went through as a kid and purely what I know as a chartered physio. I mean, I suffered overplaying or overtraining syndrome too. I would have lost my mum when I was 15 years of age, and I didn't go through the whole grieving process. And in hindsight now, as a mature man, it sounds like, you know, hindsight's a great thing. But remember back then, all I did, I invested my whole life in hurling. And I just trained every day, pucked around every day, went running every day. And by the time I got to 18 or 19, I started developing all these overuse injuries. Purely because I was just tunnel vision, didn't grieve, plugged on through life, studied, hurled. And when you get to that age and you have hindsight now, it's great. You have no emotional awareness back then. But I do see that in kids now, and it's given me that insight to see it. So there's small things in life that you mightn't recognise that can lead to player burnout. That mightn't just be, oh, he's playing this, this and this. Delve into the other aspects of their lives, and you'd be surprised what you might find out. And that's it, guys. So I hope that's been somewhat informative. I know there's a lot in it, a lot to take in. But if you can recognise some sort of injuries that you might see in your careers, and just player welfare stuff and burnout syndrome, I think is the big thing.
Paddy, could we just ask about shin splints seem to be coming back on board again with young players and adolescents, as you said. Is it down to, or is it multiple factors like footwear, training, surface that they're training on, and is physio the way to go then to try and
well, there's lots of answers to that question, I suppose. Shin splints is a generic term used for any kind of pain down around this area or even in behind the tibia. So shin splints basically is what we call compartment syndrome, or I mean, for a fancy physio word, it's periosteitis, that the inflammation along the bone. Okay, that's caused by what? It's caused by overuse, but it's usually caused, what I see every day in the clinic is adverse foot mechanics. So you might have someone that comes in with a flat foot, you might have someone that comes in with a high arch foot. Inadequate footwear, you're dead right. So orthotics, insole prescription, deloading the kid, getting him to stretch muscles around the tibia area, looking at their hip alignment. You'd be surprised what causes the term shin splints. But yeah, invariably you have to rest. But correct shoes, correct orthotics, correct footwear, treatment is essential. Just to have a good assessment is really, really important. So it exists among all age groups, but it goes back to what we spoke about earlier about the whole growth phases. So it kind of takes into that when we talk about the heel about that thing called Sever's disease, that's a kind of a cousin to that exactly as well. So you have to look at the tendons pulling on the bones. So some kids get it because they go through massive growth spurts. So it's kind of multifaceted really. It's a lot what I just spoke about, but to prevent it, it's really a mechanical assessment of the feet, and I think you'll be on the right track. Thanks.
Yeah. Just a quick question about cramp. A couple of students who would appear to be in good condition, but they tend to cramp quickly, easily, and often. Where we have.
What age group are they?
It's say now 15 to 17 kind of.
15 to 17. Again, I go to tight into like growth spurts. So growth spurts, they will get really tight muscle. Because I remember the bone grows quicker, the soft tissues are catching up if they're quite active. It depends on where they're getting the cramps. So you can take it on a physiological point of view, you can go towards their hydration, their electrolyte composition and stuff like that. Take it onto a physical aspect from a physio's point of view, obviously it's a flexibility issue. With the last man's question, it could be down to foot mechanics. If it's cramp in their calves, it could be down to that they're flat feet, wearing the wrong footwear, not enough stretching. If it's cramps in their hamstring, then it could be a weakness in their hamstring or a weakness in their glutes, that their hamstring is overactive or firing too much and causes cramps as well. So again, it's not a simple answer. It can be electrolyte composition and it can be physical. I would, as a physio, strip them down, full mechanical assessment and address everything I see. So that should help a lot.
And can I just ask you, Paddy, like if I was to say to them, okay, get the help, should they go towards a physio, should they go towards a physiologist, who should they go towards?
I would start with your physiotherapist, chartered physiotherapist, I really would. And it's usually mechanical in origin, it can be sorted. But your GP can do blood tests as well. I can send them off if there's any competitions, any blood findings that we're not sure about. But I would go to your chartered physio first. And if that chartered physio is kind of concerned, you could obviously go on to your physiologist then.
Paddy, just one thing there. I was involved in the 115 last year, so other guys here will have examples of this. But one young fella went to his physio and was told to take 2 to 3 weeks rest, right? But this one he came back to like to me over the winter. He took 3 or 4 days, came back in the following Saturday. How'd you go on the physio? 3 days rest was fine. But what happened was his dad dropped him to physio. He went up to town and picked up 40 minutes later. Come out to the car. How'd you go on? Take 3 days rest. He rubbed me out and fine. Okay, now I met this young man in a hard cup match over the winter, and he actually told me in the stand himself that he made an awful mistake. He told me 3 days rest was fine, we needed 2 or 3 weeks, and impacting his performance, and there really was a fear that he was going to be dropped off the count under 15 panel then, and that would affect his progression forward to count under 16 and count miles and what was on with it. Would you see in the clinic that you'll have young fellas coming in, and unless you go to their parent or unless their parents go to you to ask them if this is example going forward, like is this going to be an issue like that? Players to go to physios, they're told one thing to do the other thing, and then it comes back to haunt them down the line. Like this young fella actually broke down to me in the stand at that day at the match, and I'm sure guys from Clare and Water from Cork, I see this going on too, you know.
Yeah, well, you did say that's your classic signs of overtraining syndrome as well. If the kid is emotional, that's number one. If the kid is obviously trying to play off the physio to the coach to the parent, that's number two, is abnormal behaviour there. So I agree with you 100%. I mean, like I said, kids want to play all the time, non-stop. You cannot wait to get off the course, you cannot wait to get out of the boots, you cannot wait to start playing again, even if they have an injury. So my advice there is that the chartered physio in question there should always ensure that there's a guardian present. Like if he's under 18 or she's under 18, you have to have one of the parents present. And if one of the parents is kind of from the locality and trusts you so you can see them, which sometimes exists, the phone call has to happen after. And what your findings were clinically and what your recommendations were clinically, that's the most important. So communication from the physio to the parent, number one, and communication from the physio to the coach, number two, and vice versa, as a threesome.
And I think all those coaches then should really, we see an injury that we should be discussing that with the child's parent, not just himself one-to-one.
Absolutely, yeah. I mean, I would make it a point that I would liaise weekly with most coaches that I deal with within the clinic. And it's hard to do, it's bloody busy, but you can do it by text, WhatsApp, email. There's a con call that we do every week with the seniors. We have a software we record and it's constantly played. So there's lots of ways of communicating, like Owen spoke about Dropbox, lots of ways of communication. But to get back to the core of your question, I suppose you said about the kid not wanting to be dropped and lying, not semi-lying, telling white lies that he wants to keep his position on the team. I mean, I've done that, of course. I mean, I've done that as a 20-something-year-old. You know, I mean, that happens. Sport is like that. You mean you tell us white lies about injuries, not feeling sore. You don't tell the physio because you're afraid to lose the jersey on your back. And I did that to my detriment as a kid. I mean, gee, I just lied about having pubic bone overload till I was walking like John Wayne after the match and trying to pop pills and play hurling and not tell anybody about it. Kids will do that. So you're right, James. I think it's important that you spot that and report it. But liaising with parents is so important. It's so important.
Okay, I think we'll leave it there. Thanks very much, Paddy, for a fantastic talk.